can present now Dr. Andrea Kovacs. Andrea has been working, is working, her career is essentially a model career on from the times of the discovery of the HIV here in the United States, and continues with her virology and discoveries, particularly with application or with in minority populations, including women, children, pregnant women. She is the professor of pediatrics, pathology, and laboratory medicine at University of Southern California, and has dedicated all the time to the underserved populations using innovative strategies, multidisciplinary care, and now focusing on not only on HIV, but also on HCV. So with that said, Andrea, all yours.
Great. Screen one. I'm going to just set it up right now. So just give me 1 second. I'm honored to be asked to speak at this webinar. I've spent my whole career on pathogenesis studies of HIV and co-viral infections. So HCV infection is a curable infection, even in HIV co-infected individuals, and yet access is limited worldwide. What I'm going to do at first is I'm going to do a quick overview of the epidemiology, and then I will discuss some of our published work that leads into our work on the impact of HCV cure on immune activation and liver fibrosis. Worldwide, there are about 50 to 70 million people who have chronic hepatitis C, with up to 1 million new infections yearly. But as of 2022, only about 36% of the people worldwide know their diagnosis. In the US, there's about 2.7 to 3.9 million people infected chronically with hepatitis C. There are 2.3 million estimated worldwide, according to the CDC, and half of these are infected through injection drug use. Despite the availability of curable DAAs, however, only about 20%, or 12.5 million people, have been treated with DAAs by the end of 2022. And this figure here kind of shows you where the highest percentages are of viremic infection, and you can see Russia is one of the big places. Now, another important group of people are women of childbearing age, and this is a modeling study published recently. And it's estimated that almost 15 million women of childbearing age are infected with hepatitis C. And of these, almost 30,000 have been pregnant, with a 5 to 15% estimated mother-to-child transmission rates. And of these, 3.5% have chronic hepatitis C. The figure shows the prevalence of HCV worldwide in childbearing women, and you can see again the areas that are most infected are, the Southeast Asia and Russia. So the studies I'm going to present right now of HIV and HCV are nested within the Women's Interagency HIV study. It's now called the MaxWise Combined Cohort Study. The advantages is it's a prospective study. Samples are collected, history is taken, physicals are done. The study started in 1994, so you can have prospective and retrospective samples to answer specific research questions. So the research questions that we're focusing on include: what are the long-term consequences of HIV, HCV co-infection on immunopathogenesis and disease outcome, specifically AIDS and fibrosis of the liver? Then the question is, well, what if both viruses are treated? So there is no longer viremia. How does that change things? How does that impact liver fibrosis? But there are many complicating factors. For one thing, people are aging through a cohort like this. Women go into menopause. And it's important to determine what happens after a DAA treatment and the effect of all these factors such as aging and menopause. So this is essentially our hypothesis. The figure demonstrates our hypothesis relating to pathogenesis of co-infection. Immune activation and dysregulation are driven by the viremia of these two viruses. I'm going to use the laser pointer. So HIV viremia, HCV viremia, leading to risk of AIDS and liver disease. Now, ongoing immune IgU amplifies this activation because injection drugs are highly activating and also impact the liver. Now, additionally, aging and menopause increase immune dysfunction. The figure on the right is a little bit more mechanistic. It's very complicated, and I won't go through it, but essentially the two viruses act together to cause activation, T cell senescence, T cell exhaustion, changes in the maturation of T cells, activation of monocytes, and then all these cytokines that are promote chronic liver fibrosis. So now we look at what are the consequences, the clinical consequences of the impact of co-infection on pathogenesis of disease. If untreated, co-infection impacts the innate adaptive immunity, leading to CD4 depletion, importantly, CD8 T cell exhaustion, and then as a result, AIDS, HANA diseases such as cardiovascular disease and liver disease. This especially occurs more rapidly if there is hepatitis C co-infection. So I'm next going to focus on what is the mechanism of this rapid progression. There are many studies that have looked at disease progression when you have HIV, HCV together. This is an older study that we published, but it's very relevant as we move on to look at the impact of cure. So how does HCV and HIV disease progression, how does that, what are the mechanisms that cause this progression? So we looked at this, and in this slide, you can see that the Kaplan-Meier's show the probability of being AIDS-free or of dying or being or remain AIDS-free if they never had a CD4 count less than 200. So this is AIDS-free for all. This is for those who die, and this is those that never had a CD4 below 200. The blue line includes HIV positive only women, while the other lines show the risk of AIDS by HCV RNA level. And as you can see, the higher the HCV RNA level, down here is the highest, the higher is the risk of AIDS and death. Here, the death is at, it's the various highest level, which is, over 3 or 4 million copies, is predictive of AIDS. And then here you still see that the HIV only doing better. This kind of tells you that treatment may be very, very important in co-infected people for HCV. So here we show you the association of CD4 and CD8 activation with HCV viral loads. So now we're going one step further. How does this affect that activation? What is the mechanism? And you can see here in multivariate models that those who are have the highest level have higher activation levels than those who are HIV only infected. Same with HCV, same with CD4 cells. As shown in the slide, in the upper panel I just reviewed, and then in the lower panel, you'll see that there's a threefold increased risk of developing AIDS and dying when comparing the women with the highest level of activation with those with the lowest level of activation in multiple models, adjusting for viral load, CD4 and viral load. But here it's extremely, that tells us that this is probably one of the mechanisms that is the cause of disease progression. Because once you get CD8 activation, the CD8 cells become energetic. So in summary, HIV HCV viremic women had significantly higher percentages of activated CD8 T cells than HIV only infected. And this is associated with higher incidence of AIDS-related illness or death. We then went one step further to assess if T cell activation is related to HLA genes. This study evaluates the link between HLA and T cell activation as a potential causal pathway leading to HIV-HCV disease. We know and I've shown that T cell activation increases AIDS outcome. HLA has been shown to affect disease progression. So we looked at this in relation to activation. As you can see in this this slide and these two panels, we show the relationship between CD8 and CD4 activation and significant HLA alleles in multivariate models. The two important alleles that I put the arrows, you could see these here, are associated with higher, so B1801 is associated with very increased CD4 and CD8 activation compared those with the allele compared to those without the allele. And then the B5703 has significantly lower levels of activation. And you can see this in this next slide, where the betas, which is the decrease or increase, and here B1801 shows an increase, a mean increase in activation levels, CD8 activation levels, among those with the allele versus without the allele. Similarly, the B5703 shows decreased CD8 activation levels. So inclusion for this particular study, we found 10 HLA alleles that were associated with both CD8 and CD4 activation. When an allele was associated with both, the direction of activation was the same, which makes sense. These findings suggest that a person's HLA allele type may play a role in modulating T cell activation independent of viral load, and sheds light on the relationship between host HLA, T cell activation, immune control, and HIV pathogenesis. We next turn to to look at the impact of HIV-HCV co-infection on liver disease. It's well known that HIV patients who are co-infected with HCV have accelerated progression of liver fibrosis. The liver is obviously an incredibly important organ and modulates CD8 T cell activation and destruction of activated CD8 T cells. Activated CD8 T cells that traverse the liver may induce activation of stellate cells and Kupfner cells, leading to apoptosis and fibrosis. But there are many factors that impact fibrosis. There are HIV-related, HCV-related, and host-related. And all of these need to be in consideration as you do studies, epidemiologic studies of the pathogenesis of liver disease progression. And that's why our studies that I'm presenting are teasing this out. And here, this is the same cartoon, same diagram, looking at all the factors that, and I won't go into it, but it shows you how complex this is, and you have to just tease it apart and focus on one area at a time to be able to, and then put it all together. So the impact of HCV cure on immune activation and liver fibrosis in aging women is the next topic. The PIs are myself and Dr. Tien from UCSF, and this is funded by an R01 through NIDA. So the central hypothesis of this study, which builds on the information we learned from the other studies, is that HCV cure, after HCV cure, co-infected women who are aging will have impaired liver fibrosis regression because of HIV-associated immune dysregulation and an increased risk of metabolic perturbations, including hepatic steatosis, fatty liver, for instance. There's a non-alcoholic fatty liver leading to non-alcoholic steatohepatitis. This is increased in co-infected patients, and it increases with age, and it increases as women go into menopause. And with residual and continued liver injury, there will be persistent immune activation dysregulation. So the studies that I'm gonna read next, a couple of them published, the rest are preliminary data, are all nested within the Women's Interagency HIV study. So the first thing that I wanted to focus on is this is a longitudinal cohort study where we assess the fibrosis progression across reproductive age using validated serum fibrosis markers, specifically APRI and FIB4. And what you can see here, and we use the anti-Mullerian hormone as a measure of reproductive ages. So this looks at, and this is done longitudinally and adjusted, age adjusted across reproductive age. And you can see that pre-menopause, it's lower, but once you start getting to in the perimenopausal period, there is increased fibrosis. And that's true both, looking at FIB4 and APRI. And what I guess what is new in this study is that fibrosis accelerates with a reproductive aging, but what's new is that this accelerated fibrosis begins in this perinatal period, highlighting a previously unrecognized group of women at increased risk for advanced fibrosis and associated complications. So this is an important finding in that it explains some of one of our hypotheses about liver fibrosis progression, and that aging and menopause together alters progression of liver. And most likely this is due to, it is probably depleted to estrogen, but there are many other factors that come into play. This particular study we published recently, and this looked at the longitudinal assessment of enhanced liver fibrosis score following DAA treatment. And you can see this looks at the trajectories. We used enhanced liver fibrosis score, ALT, APRI, in 116 women with co-infection over a 4-year period. There was a rise in serum biomarkers of liver fibrosis early on. So we looked at one year before, 1 to 2 years before, 1 year after, and then more than 1 year. And what is interesting is that followed by declines, there's an unexpected rise starting a year after treatment. So it's sort of like flattens off here. The flattening of declines over 1 to 2 years after treatment suggests that continued monitoring of liver fibrosis and interventions to mitigate its progression in people with HIV is essential. So I think we need to be looking beyond 1 to 2 years. Now I'm going to turn to the unpublished studies, and these are focusing again on, we'll be focusing on the impact of T-cell activation and non-invasive markers of liver fibrosis among those with and without hepatitis. We will then look at alterations in various markers of activation after cure, and then we will also be looking at viral reservoirs. So in this study, the table of the results for the CD4 and CD activation markers that you see here are evaluated in association with FIB4. So what you see is a clear-cut increased fibrosis with CD4 activation, so threefold increase. There's a trend for a CD8 increase, but importantly, having resting T cells is protective, and that is interesting because it may have some impact on viral reservoirs. So this particular study, I'm only giving you highlights because all of these studies are extremely complex and have many, adjustments and very detailed statistical analyses. But CD4 activation is associated with markers of liver fibrosis in co-infected women, independent of viral load. And these resting T cells, having high levels of resting T cells seem to be protective. That would mean there would be probably fewer activated T cells. But the finding that CD4 positive T cells are increased and cause increased activation, this may impact HIV reservoirs, which is what we're interested in looking at. So here we look at first the impact of HCV cure on immune activation dysregulation, and then HIV reservoirs. This is the team that works with me on these studies. We include 297 women. They are matched to HIV infected only women by age, gender, race, viral load, and visit. And all the patients that we studied had HIV viral load less than 200. So here we are, we're testing the hypotheses. We've got one virus where the patients are non-viremic, which is HIV. And now we're looking at the second virus, which is HCV. And we're looking at the impact of curing that virus. And what does that do to liver fibrosis progression? What will that do to AIDS progression? And how does that impact all the immunologic markers that have been found to be abnormal with co-infection? So we've now, this is preliminary data. We've now had studied and sample analyzed about 218 PBMCs. Huge number of subcells are sorted. I'll go over that. And 92 women for whom we have 2 time points before and after DA. We are now analyzing this data. And these are the markers we're studying. So we did 13 color flow, and we are very interested in looking at, maturational changes, what happens to Tregs. We're looking at senescence, exhaustion. What I'll present today will be mostly on the activation data. And we're also interested in monocytes and all these other markers. What happens after you cure HCV and you are immune your viral HIV viral load is undetectable. So in this particular slide, we look at the impact of DAA treatment on CD4 and CD8 activation. And this is a small sample size, so you have to keep that in mind. But what it does show that there is a decline in activation levels from pre-DAA treatment to post-DAA treatment in some of these women. And it's mainly those that started off with high activation levels. And that's true for CD8 and CD4 T cells. We also looked at Tregs, and you do see there's a decline in a group of women who had high Tregs to more, more standard Tregs. And you don't see that in the controls. Remember, we ran these samples together, and they're all matched, except there is no HCV viremia or HCV cone. There's no HCV viremia in this group, and the HIV RNA is undetectable in both groups. So this study shows that a preliminary data with a small sample size, but it appears that following DAA treatment, both CD4 and CD activation seem to decrease after some treatment in some co-infected women. Similarly, we see changes in Tregs, but we will not be able to get to the truth here really until we do a further analysis on the bigger sample size of 92 women and at multiple time points. So we now turn to measuring HIV reservoirs, which again this is our team who are studying HIV reservoirs. And first, I want to summarize a little bit about what we did here is we sorted on specific cells that we want to analyze, not only for viral reservoirs, but also to look at gene signature expressions. And so we're planning those studies. Past studies have produced mixed results on how DAA-mediated HCV cure. They focus mainly on CD4 cells and total HIV DNA. Our assays include 2LTR to assess not only HIV DNA, but also the ratio of latent 2LTR and total HIV DNA. We first looked at non-activated HLA-DR cells, which are the resting cells that represent the potential latent reservoirs. So I'm not going to go through this in great detail, but you can see from this is our methodology for ddPCR. This is what it looks like when you look at, and then this is analyzed, and these little dots represent the 2LTR and the CCR5, which is our control. So first, we sorted the 7 populations and then extracted the DNA and then ran samples in replicates, and we focused on GAG, 2LTR, and CCR5, and we adjusted for the number of cells using CCR5. And so here you see small sample size, but there's 6 patients, 3 are co-infected and 3 are mono-infected matched. The average of these appear that the co-infected have higher GAG before and after, but with a decrease, somewhat decrease, is probably not statistical, but we won't know until we have much larger sample sizes. And 2LTR before and after, and these are the HIV only. So I suspect that we will be able to show this, since we were able to definitely see a decrease in several of these patients, especially these 2 high ones. So in conclusion, our studies from the WISE and now the WISE combined cohort study have demonstrated that HCV infection has a major impact on immunopathogenesis of HIV and HCV disease. Very preliminary data suggests that with controlled HIV and HCV cure, there's improvement in activation and decrease in HIV reservoirs. These data suggest that access to DAA would have a major impact on the worldwide problem HCV and HIV co-infections. So this should be, looking at the diagnosis and then immediate treatment would have major impact. Lastly, I would like to thank very special thanks to Women and the Wise who participated in these studies and our funding partners. Our studies were funded at first by NIDA and currently, by NIAID, and currently are being funded by NIDA. The Max Prize is funded by NHLBI, is the major agency, and then almost every other agency is involved. And that's it. Thank you.